The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shannon McKernan, and today I'm interviewing Dr. Neelima Dandaluri from U.S. Oncology, Virginia Cancer Specialists, an author on selection of optimal adjuvant chemotherapy and targeted therapy for early breast cancer, ASCO Clinical Practice Guideline Focus Update. Thank you for being here today, Dr. Dandaluri.
Thanks for having me.
So first, can you give us a general overview of what this guideline covers?
Yes. So this guideline covers specifically two clinical situations. The update focuses on women with early breast cancer that have HER2-positive disease and have had all their tumor removed. And it focuses on what is the appropriate adjuvant therapy for those women with HER2-positive breast cancer and early breast cancer. And within the last year, we've had data showing that pertuzumab improves outcomes when it is added to trastuzumab and chemotherapy-containing regimens. The other HER2-targeted agent that this guideline update covers is neratinib, which is an oral small molecule targeting HER2, and its role in women or men that have finished 1 year of adjuvant trastuzumab. The third topic that this guideline update covers is in women that we've chosen to give preoperative chemotherapy with HER2-negative disease, and at the time of surgery, they have a residual cancer burden. For those patients in the past, we never had a standard therapy that we can discuss with them, and this guideline update focuses on the use of capecitabine in women with early breast cancer who had standard preoperative chemotherapy and had a residual cancer burden, and whether it is appropriate to use capecitabine in those patients.
So what are the key recommendations of this guideline?
So in the HER2-negative population, in patients that underwent standard neoadjuvant therapy or preoperative therapy with anthracycline and taxane-containing therapy and go on to undergo surgery, but have residual cancer burden or at higher risk for relapse. And therefore, what we found with the CREATE-X trial is that these patients benefit from the incorporation of adjuvant capecitabine. So in our guideline update, we added that capecitabine should be discussed with patients who have residual cancer burden. The caveats, though, are that in North America, the dose of capecitabine that we use is associated with higher toxicity, primarily in the elderly group, but also in the general population. Capecitabine is tolerated differently. Therefore, we did put that the dose should be the dose of 1250 mg per meter squared in our guideline that was used as part of the trial should be is associated with higher toxicity in patients greater than or 65 years or older. So that's one. And we also thought that in general, the people with HER2-negative disease that would benefit from the adjuvant capecitabine are those with triple-negative disease. Regarding other key recommendations, in the HER2-positive space, we recommended a year of pertuzumab be discussed with patients that have high-risk HER2-positive disease. The Affinity trial incorporated node-negative and node-positive, and the follow-up is early. But based on other data, we know that the majority of women with HER2-positive disease and node-negative disease seem to do well with the incorporation of chemotherapy and trastuzumab alone. They don't seem to have poor outcomes without additional therapy. However, the follow-up is early, but the guideline panel felt that those with the highest risk HER2-positive disease are the ones that would benefit from the 1 year of pertuzumab added to standard trastuzumab and chemotherapy. The other key recommendation is that neratinib, which is an oral tyrosine kinase inhibitor, may be used in the early breast cancer, HER2-positive breast cancer setting. Now, the caveat to this is that this trial was performed using neratinib in the adjuvant setting in a population that never received pertuzumab. Additionally, the trial was performed when we didn't have outcomes necessarily or events that we knew that the node-negative population probably does well with chemotherapy and standard 1 year of trastuzumab. Therefore, we think that the people that benefit most from the neratinib for a year, which is 240 milligrams a day, are those that have node-positive disease and those with hormone receptor-positive disease.
Can you tell me about the signals approach to guideline updates and about the signal that prompted this focus update?
We have a very rigorous methodology in how we undertake guidelines within ASCO. Sometimes there is a seminal article that is published that has the potential to impact the practice of clinical medicine. And that's what happened with this, the signal that there is a subpopulation of HER2-positive breast cancer that has a high risk of recurrence despite therapy with chemotherapy and trastuzumab. And 2 papers were published in 2017 utilizing pertuzumab or neratinib in these patients at highest risk with HER2-positive and early breast cancer. Similarly, the signal in this unmet need of HER2-negative patients with residual cancer burden, there was a seminal article published in the New England Journal that showed that capecitabine improves outcomes for this subpopulation of patients. So therefore, when these 3 articles were published, instead of waiting to do a new guideline or overhaul the entire guideline, we used the signal that these 3 articles made a difference in impacting care and acted accordingly.
So finally, how will these guideline recommendations affect patients?
These guideline recommendations have the potential to affect those at highest risk, and they'll give patients another option to discuss with their physicians regarding those with HER2-positive breast cancer, node-positive breast cancer. In addition to the trastuzumab and the chemo, their physicians will now discuss with them the pros and cons of pertuzumab. Any therapy that we give has to be individualized, and with pertuzumab we have a higher incidence of diarrhea, and that's something that they'll have to discuss is the potential benefit of the pertuzumab versus the potential risks. Similarly with neratinib, those patients that may not have received pertuzumab or that may have a very high risk of recurrence after receiving trastuzumab and chemotherapy, those patients now have the opportunity to discuss neratinib, which is an oral tyrosine kinase inhibitor, and a significant side effect of neratinib is diarrhea. And so the patients will be able to discuss the potential risks and benefits of the neratinib. The catch with the neratinib is that in North America, specifically the United States, those at highest risk may also have received pertuzumab, and we really don't have any data in that population that neratinib adds additional benefit to those patients. And with any treatment recommendation, patients really need to discuss the risks and benefits of the therapy. In the triple-negative breast cancer, if someone's not eligible for a clinical trial and they have a significant residual cancer burden after receiving traditional anthracycline and taxane containing neoadjuvant therapy, capecitabine gives them a significant option that improves survival. And capecitabine is an oral drug. It's generally well tolerated. Again, the big issue is going to be with capecitabine that they need to be careful of the dose that was used in the study that affected the survival benefit and whether that can really be tolerated in every population. One other consideration to think about, especially in the HER2 positive space, is that both the trials, the Extenet, EXTENET trial and the Affinity trial, they produced results and they were positive trials. However, the degree of benefit was less than we expected, and I think that that's largely due to the fact that trastuzumab and chemotherapy are excellent therapies. Therefore, there were a lot of subgroup analyses done that were not statistically significant, and that's why, as a panel, we did add some qualifying statements to the guideline, despite the lack of robust p-values to discern that this subgroup of HER2 positive may benefit more from neratinib, or this subgroup may benefit more from pertuzumab. We really couldn't put that in the bullet of the guideline. However, the expert panel did make some recommendations regarding which subpopulations they thought that we thought would derive the most benefit from these agents.
Thank you for your insights on this guideline, and thank you for your time today, Dr. Dindalori. And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.